Hi guys, welcome back to my channel. Without further delay, let us start with the second part of GIT integrated.
Okay, so let us start by talking about the anatomy of the esophagus, right? So, esophagus will divide it into three parts: the upper one third, then middle one third, and then finally lower one third of the esophagus, right? So, upper one third is supplied by inferior thyroid artery and inferior thyroid vein, right? You should remember from the arterial anatomy that inferior thyroid artery is a part of thyrocervical trunk, which is the first part of subclavian artery, right? Then the mid esophagus is supplied by aorta and azygous vein, while if we talk about distal one third of esophagus, it is supplied by the branch of left gastric artery, and the vein is coronary vein, which drains into portal vein, right? Why this is important to know? Because if there are metastasis, like if in case of esophageal cancer there are skip metastasis due to longitudinal lymphatics, and via the portal vein they travel to the liver. Therefore the most common site of distant mets in esophageal cancer is liver, right? Then the distance of esophagus measured from the upper incisor, right, it is 40 centimeter, right? It has some constrictions. So the first constriction is at C6 level, that is due to cricopharyngeus, and it is also called an anatomical sphincter, and it is the upper esophageal sphincter, right? It is 15 centimeter from the upper incisor. Then at 25 centimeter is the second constriction, where the arch of aorta and the bronchus crosses it, right? And the third constriction is at T10 level, which is the diaphragmatic opening for the esophagus, right? Then lower esophageal sphincter, it is basically a physiological sphincter, and the lower esophageal sphincter normally is in a contracted state, right? That is the relevant anatomy. And one more thing, remember that in esophagus serosa is absent. All right, now talking about some particular conditions in esophagus. All right, so the first condition is called as presbyesophagus, right? It is the abnormality of tertiary peristalsis, right? There is increased frequency of tertiary peristalsis, and remember, the tertiary peristalsis is peristalsis that takes place in between two meals, right? During the meals, we encounter two types of peristalsis, primary and secondary. The primary peristalsis is the one that is responsible for pushing the food, and if in due to some case the food is stuck, then secondary peristalsis takes place, right? But tertiary peristalsis, it is seen in between two meals are taken, right? That is, it is intermeal peristalsis. Then some infectious condition. First is candidiasis. You just need to know the buzzwords here, right? In candidiasis, what we will find: shaggy deposits, right, and worm-like ulcers. CMV, there will be serpiginous ulcers, right? So worm-like ulcers will be candidiasis, and serpiginous ulcers will be associated with CMV. Then in herpes, right, there will be small ulcers, right, and the margins are raised in case of herpes, the margin of the ulcer, right? Then injury to esophagus by corrosives, right? It can either be an acid injury or an alkali injury. Remember, alkali injury is more dangerous than an acid injury as it causes a deeper penetration, right? Acid can lead to coagulative necrosis, while with alkali there is liquefactive necrosis, and in acid there is pyloruspasm as well, right? How do we manage it? By firstly giving fluids to the patient and performing an endoscopy. If stricture has formed, then a balloon or a bougie may be used to dilate it, and in severe cases esophagectomy may also be performed, right? Here the point needed to be noted is that for esophageal replacement, the ideal substance is colon more than jejunum, right? Remember that whenever we perform surgery for esophagus, the ideal replacement agent is stomach. But in case of injury with corrosives, right, it is generally due to ingestion. Therefore, stomach might also be damaged. Hence, here stomach is not used. What we used is instead colon and jejunum. All right. Then there can be a foreign body in the esophagus, right? Now, the foreign body can be stuck at this point. This is the most common place. That is the first constriction of cricopharyngeus where it can be stuck, right? And it can lead to iatrogenic perforation of esophagus if it is a sharp foreign body, right? So if there is a foreign body in the esophagus, endoscopic removal needs to be performed, right? Investigation of choice is CECD and management is thoracotomy and repair, right? And remember a thumb rule here that in cases of elective surgeries, a posterolateral thoracotomy is done, right? While in emergency surgeries, always anterolateral thoracotomy is done, right? This will be very helpful in answering a lot of questions. Then between cricopharyngeus and thyropharyngeus, there is a potential space which is called as the Killian's triangle, right? And through this space, there can be bulging of the mucosa of esophagus, that is known as Zenker's diverticulum. It is a false diverticulum as all the layers are not involved, right? And the most common complication associated with it is aspiration pneumonitis, right? How do we manage it? If it is less than 2 centimeter, then a diverticulopexy with cricopharyngeal myotomy is done. While for larger diverticulae more than 2 to 4 centimeter, right, endoscopic diverticulopexy is done, and this is called as Dolman procedure. All right. So these were some of the conditions that affect the upper 1/3 of the esophagus, right? Moving ahead, in middle 1/3 of the esophagus. So first we can see parabronchial diverticulum, and remember that this is the only true diverticulum that can be seen, right? It is seen with TB and histoplasmosis. All right. Second thing that can be seen is squamous cell carcinoma. It is the most common cancer in India, right? But now due to increase in lifestyle changes and westernization, we are moving towards like the incidence of adenocarcinoma is rising, but still for MCQ purposes, the most common cancer is squamous cell carcinoma. Okay. What you need to remember is that first it is affecting middle 1/3 of the esophagus, right? It is associated with tylosis, autoimmune diseases, Zenker's diverticulum, and achalasia, right? How do we manage it? First, it is the investigation of choice is endoscopic biopsy, right? And PET CT is the investigation of choice for staging. But if the question says T stage or depth of the cancer, or N stage, that is involvement of the nodes, then the answer will change to endoscopic ultrasound, right? This is for staging. Overall, if nothing is being mentioned, then the answer will be endoscopic biopsy, right? Most important prognostic factor is T stage. Okay. Remember in GIT again, the thumb rule is that T stage or depth of invasion is the most important prognostic factor, and EUS will be the investigation of choice for T stage. That is more than enough to know. Then this is the TNM classification. It's not very important, but it's good to know because this is the staging that is followed by both esophageal cancer, stomach cancer, etc. Right? So it's very easy. T1 is involvement of mucosa and submucosa. T2 is muscularis propria. T3 is adventitia. T4A is resectable structure. Just remember this, right? T4A is involvement of adjacent structures, and it is a resectable disease, right? So what is involved? Pleura, pericardium, and diaphragm. While in T4B, there will be involvement of aorta, vertebra, and trachea, and therefore it will be unresectable, right? N1 is just 1 to 2 nodes, N2 is 3 to 6, and more than 7 nodes is N3, right? Then what do we need to know is the surgery or management of esophageal cancer, right? So we'll come back to it. First, let us see the other variety, which is the adenocarcinoma of esophagus, right? So the predisposing factor for adenocarcinoma is Barrett's esophagus, right? It is also associated with Crest disease, that is limited sclerosis, right? And GERD. Right, why GERD? Because GERD will lead to Barrett's and Barrett's will lead to adenocarcinoma. Right, now let us talk about the management. And yeah, adenocarcinoma, it is involving the lower 1/3 of the esophagus, while squamous cell is involving the middle 1/3 of the esophagus. Right, now for management, the surgery is esophagectomy, right? And very important to know is margin. The proximal margin is 10 centimeter and the distal margin is 5 centimeter. Right, for lower 1/3 cancer, transhiatal orange surgery is done. Right, here there are two incisions. First is a midline and second is in the left lateral neck. Right, and anastomosis is then done by the neck incision. Right, so this will be for adenocarcinoma mostly. Alright, then for mid 1/3, Ivor Lewis is done. Right, in Ivor Lewis there is a midline incision and a thorax incision. Right, and anastomosis is done by the incision in the thorax. Right, and finally for upper 1/3, McKeown, 3-field surgery is done. Here there are, as the name suggests, 3 fields. First is midline, second is thorax, and third is the neck. And since neck is being involved for incision, anastomosis is done in the neck. Right, so these are the 3 operations. Right, they're easy to remember. First is midline and neck, second is thorax and midline, and third thorax, neck and midline. Right, so 3-field is McKeown, then through thorax and midline this is Ivor Lewis, like in mid 1/3, and lower 1/3 में for adenocarcinoma this is Oranger, which is transhiatal. ठीक है, because adenocarcinoma is lower, so definitely transhiatal means through the hiatus. Right, so this is the diaphragm, and via the diaphragmatic hiatus, and via the diaphragmatic hiatus it would be easier to operate those cancer which are situated in the lower 1/3 of the esophagus. Right, so this was surgery. Then we can also give radiotherapy and chemotherapy. Right, the chemotherapy is 5-fluorouracil and cisplatin. This is also mostly given in GIT cancers. Right, and it is given in lymph node positive disease, while if the disease is advanced, right, then neoadjuvant chemotherapy is done. Also, combining radio and chemotherapy is a better option than giving chemotherapy alone. Now in cases of esophagectomy done for cancer, right, here stomach is fine, so for esophageal replacement the ideal material or the ideal organ would be a stomach. Right, and the artery that is used is right gastroepiploic more than the right gastric artery. Right, after stomach, colon or jejunum can be used, but first here stomach would be the preferable option. Right, so this completes cancer. Let us look at the other conditions affecting the lower 1/3 of the esophagus. Right, so we were studying diverticulae. So Zenker's diverticulum was in the upper esophagus, then parabronchial was in the mid. In the lower 1/3 we will see epiphrenic diverticulum. Right, it is not important, just that it appears as a retrocardiac shadow, just like hiatus hernia. So on chest x-ray, epiphrenic diverticulum forms a DD for hiatus hernia. Alright, then Bohr syndrome. Right, so for Bohr syndrome, just remember Mechler's triad. Okay, what is Mechler's triad? Right, so they have similar features like retching. Right, here also we will have retching. In Mechler's triad there will be chest pain and subcutaneous emphysema. See, Bohr syndrome is what? It is perforation, right? And what is it? It is a perforation of lower 1/3 of esophagus. Esophagus is containing gas, so if gas would leak out, it would lead to subcutaneous emphysema, right? And subcutaneous emphysema would cause chest pain and retching. While if the question mentions retching and upper abdominal pain, it is usually associated with Borchards triad, and that is with gastric volvulus. Alright, let's go back to our notes. right? So Bohr syndrome, the investigation of choice would be CCT if the patient is stable, while if for unstable patient, a contrast study with iohexol is done, right? It is managed by performing a thoracotomy and ICD in a stable patient and cervical esophagectomy followed by anastomosis 10 to 12 weeks later if the patient is unstable, right? It is an obvious thing that if a patient is unstable, then the first thing would be to manage him or to do emergency management, and later we require to do a definitive corrective anatomy, right? Damage control surgery we read in general surgery long time back. Fine. Then Barrett's may it is an important topic. It's a favorite question of AIMS people, right? What they show is generally a histoimage, right? Here you can see esophagus, right? Esophagus is made of squamous epithelium and stomach is made of columnar epithelium, right? So there is metaplasia, right, at the transition zone, which is known as squamocolumnar metaplasia. Here we can see the stratified squamous epithelium, and here you can see glands, right? And this is the columnar epithelium, right? When you see such image, it is usually metaplasia, and usually it is Barrett's esophagus, right? And the characteristic thing is that with Alcian blue stain, right, it will stain mucin because these glands, right, they contain goblet cell, right? This is esophagus only, right? Esophagus should be like this only in its entirety, but here the stomach like epithelium is coming, so that is why it is called as Barrett's esophagus, right? Remember, there are two types, long segment and short segment. Long segment is more than 3 cm and short segment is less than 3 cm. Then chromoendoscopy is done with Lugol's iodine for the squamous part and methylene blue, which just saw columnar part. And the management is there is Seattle protocol, which is the surveillance and biopsy, right? What it states that for Barrett's, a 2-yearly protocol or a 2-yearly follow-up is done. If dysplasia is present, then we see whether it is low grade or high grade. For low grade, argon photocoagulation or RFA is done and 6 monthly follow-up, while high grade 3 monthly follow-up, and if there is cancer, then surgery is done, right? This is surveillance post biopsy, right? Then the next condition is GERD, which is again very important because GERD will lead to Barrett's, and long-standing Barrett's leads to achalasia, right? The most common predisposing factor for GERD, which is gastric esophageal reflux disease, right, is that, see, this is the esophagus and this is the diaphragmatic opening, right? And this is the intra-abdominal esophageal length, right? The most important factor for maintaining the tone of the lower esophageal sphincter is the intra-abdominal length of the esophagus, which is normally 3 to 5 centimeter. If it reduces to less than 2 centimeter, it will cause relaxation of the lower esophageal sphincter and there will be reflux of acid, right? And this is what is GERD, right? This is called as increased transient lower esophageal sphincter relaxation, right? The investigation of choice here is an endoscopy, while the gold standard is 24-hour pH monitoring. This is also a favorite question everyone asks, right? So what we calculate is the Demeester score, and it is more than 14.7. The unit is Bravo 24, right? And what we see is that the pH is less than 4 for more than 4% of time in 24 hours. Okay, these are very important values. You should note them to heart, right? For management, the surgery is fundoplication and shoe shine maneuver is done, right? Imagine like how it is done. This is a shoe, right? How you polish the shoe by placing a cloth and pulling from here and here. So similarly, fundoplication is done in the same fashion, right? Now fundoplication can either be partial or complete. Complete is that it is covering the esophagus by 360 degree, okay? So this is complete, right? And the complete fundoplication is called as Nissen's fundoplication. And very important question coming up next, that the most common complication of Nissen's fundoplication is gas bloat syndrome, right? And most common, if they ask intraop, it is pneumothorax, right? Partial fundoplication can be door fundoplication, right, which is 180 degree. Toupee is the only posterior fundoplication, to 180 to 270, and Belsey mark, which is again 270. Now there are newer methods like endoscopic RFA, Lynx device. See, they are again magnets, like they are placed here and here so that the LES would be tightened as the walls are pulled towards each other. Okay? We studied one more device in the congenital anomalies, which was flourish device, right? It was also magnets used for type A tracheoesophageal fistula. Here the device is Lynx device, right? These are all magnetic devices, new things, right? Now we studied that with Nissen's fundoplication, the most common complication was gas bloat syndrome. So to prevent this, what we do is we do a floppy Nissen's fundoplication, right? That is, we just don't tighten it too much so that it causes such symptoms, right? Then the next important condition is achalasia. Everybody can identify it from X-ray that it has a bird beak appearance, right? It is of two types, primary and secondary. Primary is due to the absence of myenteric plexus, and secondary is usually due to Chagas disease. Then pseudoachalasia is achalasia due to cancer, right? And then Algroff syndrome, it is triple A syndrome, right, in which one A is standing for achalasia. Then for gold standard for achalasia is manometry. Okay, gold standard for GERD was 24-hour pH monitoring, while for achalasia it is manometry, because achalasia is basically increase in pressure, right? It is a motility disorder of esophagus, and here Chicago classification is followed, right? It is managed by either Botox or balloon, and surgery is Notes Poem, and the named surgery that is done is Heller's myotomy, right? Now let us quickly look at other motility disorders, right? First is diffuse esophageal spasm. How do you identify it? On X-ray you will see corkscrew appearance of esophagus. Okay, don't confuse this corkscrew appearance of esophagus with midgut volvulus, right? In midgut volvulus there is a rotation disorder, right? So what we will see is that the entire midgut is shifted to one side, while here this is esophagus, right? Here this is small intestine. So these are two separate things. This is midgut volvulus. It will also have a corkscrew appearance, right? So this is DES. Here there are more than 2.5 contractions, right? The pressure is more than 120 millimeter of mercury. Very important, DCI. Okay, this is more than 450, and IRP is normal, right? IRP is raised in which condition? Achalasia, right? This is what we study in Chicago classification. I'm sorry if I'm going too fast, but these are just brushing up points, and okay, I'll show Chicago classification. It's not important to learn that, but you should just have a brief idea about it. Okay, Chicago classification, this is for what? Achalasia. Okay, so according to it, there are three types of achalasia: type 1, type 2, type 3, right? Remember, in achalasia IRP is increased all the time, right? Then ineffective contraction, right? It is not seen with type 1, right? Failed contractions in type 2 and spastic contractions in type 3. Then lower esophageal pressure is more than 26 mm Hg, and type 1 there is relaxation, in type 2 also relaxation, while in type 3 there is contraction, right? DCI of type 1 is less than 100, while type 3 is more than 450, right? So why was I telling this? Because this thing, DCI more than 450, was also seen with diffuse esophageal spasm. But how will we differentiate it? That here the IRP is normal, while in achalasia the IRP is raised. Okay, just remember this, ki IRP is raised, baki it's not important. All right, so yeah, for diffuse esophageal spasm, right, what we do is just we give nitrates, right, and if it does not respond to nitrates, then myotomy is done, right. Another motility disorder is nutcracker syndrome, nutcracker esophagus, which is the most common motility disorder. Here the DCI will be very high, right? See, it is more than 8,000, right? So yeah, that completes the motility disorders of esophagus as well, right? The next thing before moving on to stomach would be just to know the C-word classification, which is done for gastroesophageal cancer, GE junction tumors, right? So here 1 centimeters proximal to 5 centimeter proximal to GE junction, right? This is zone 1. Then from here to 2 centimeter distal to GE junction is zone 2, and from this point to 5 centimeter distal to GE junction another line is drawn, right? You understand? From GE junction 1 centimeter proximal, 5 centimeter proximal, 2 centimeter distal and 5 centimeter distal. Okay, so this is zone 1, this is zone 2 and this is zone 3. Just you need to remember is that zone 1 and zone 2, that is cancers up to 2 centimeter distal to GE junction, are managed as esophageal cancer, while those at 5 centimeter distal to 2 centimeter distal, right, just these cancer type 3 wale are treated as gastric cancer, right? So this completes our esophagus.
See you for the next part where we'll be doing stomach and small intestine. Till then, have a good day and happy learning.